Bismillah ar-Rahman ar-Rahim. It will be my honor to introduce, it will be my honor and pleasure to introduce the second symposium that was run by the Emirates Society of Internal Medicine. I wish you will all enjoy the interesting sessions, which will cover one of the hot topics in the current COVID pandemics. From our experience in being frontliners for fighting against the current COVID-19 pandemic, we have recognized several manifestations that persists beyond the resolution of COVID-19 infection, what is known as post-acute COVID-19 syndrome, where the symptoms persist 3 weeks after the onset of the symptoms of COVID infection. As you all know, this topic is still under progress research with continuous feedback of patients infected with COVID infection. So we're still receiving a lot of feedbacks on the symptoms. How long does these symptoms persist and how long do they resolve? A lot of management have been tried to look at how can we resolve these symptoms and what investigations that can be done for these symptoms. These manifestations actually range from mild symptoms like fatigue, loss of smell or taste, low-grade fever, to more severe symptoms like chest pain, shortness of breath, certain thromboembolic conditions, some neurological manifestations like stroke, or even some psychological manifestation like depression. For this reason, we wanted to address the post-acute COVID-19 pulmonary complications, which holds a huge burden on the healthcare system globally, and that have affected a lot of lives and led to several morbidities and even to mortality. Today, actually, we will discuss two nice topics. First being the COVID-related pulmonary fibrosis with Dr. Yusuf Al-Dairi, and the second will be oxygen therapy in COVID patients with Dr. Ashraf Al-Houfi. I will be pleased to introduce Dr. Yusuf Al-Dairi. Has accomplished his medical degree in Aleppo, Syria in 1991, followed by where he went for his residency and fellowship in Kentucky, US, and graduated in 2008. After that, he had several consultant positions, being in intensive care in King Faisal Specialty Hospital in KSA for 6 years, followed when he joined Rashid Hospital since 2017. Dr. Yusuf is one of the pulmonologist consultant in Rashid Hospital, and we've been pleased to learn a lot from him during his stay. Dr. Yusuf, the ground is yours to start your presentation. Please do so.
Thank you, Dr. Abdullah, for the nice presentation. Assalamu alaikum, everybody. Good evening. We'll try today to cover the post-COVID pulmonary complications, not necessarily the acute presentation. So this is more after the patient has cleared the virus and what kind of complications that we'll be seeing. I'm going to try to share my screen with you. All right. Okay. Is it clear now? Do you see my screen? Okay. All right.
Yes.
Yeah. So we'll talk about certain patterns about pulmonary involvement in the post-COVID infection. What are the general risk factors? What the clinical course that we see, and what treatment options we have. This presentation has been challenging in a sense that it's a moving target. Every day there are new information and new data. I tried to limit it as much as possible to evidence-based recommendations. But again, everybody has their own opinion because it is a moving target. What we see normally with COVID when there's pneumonia, and that's not the majority. We know from experience that the majority of patients don't develop pneumonia. There's a certain percentage, roughly about 20%, 10 to 20%, will develop pneumonia to variable degrees. So in the acute phase, you have a direct viral invasion of the lung. So the receptor is the ACE2 receptor. It will cause inflammation, will cause direct destruction of the alveoli, resulting in acute hypoxemia. If it is severe enough, the patient will develop ARDS. So in this case, there will be diffuse alveolar damage, acute inflammation, and later on will progress into chronic fibroproliferative phase. But what we are seeing when patients are surviving the acute phase, so 1 and 2, the acute viral pneumonia, the ARDS, we see in 2 weeks, 3 weeks, a month, have a patient up to 6 months, we have organizing pneumonia. You're seeing a lot of ground glass opacities, sometimes fibrosis, causing decrease in lung function and affecting their general activity. And in some cases, we're seeing patterns of pulmonary embolism. Most of physicians who have dealt with the COVID-19, they've noticed the increased coagulability of the patients. D-dimer in a good proportion of them is high. The early reports of patients having DVT and PE have led the majority of physicians to be proactive and initiating DVT prophylaxis, and sometimes even in therapeutic doses, even without evidence of PE. There isn't any strong medical evidence that a certain dose is better than another without evidence of PE, but the common practice that you'll see people titrating their anticoagulation according to the level of the D-dimer and how sick the patient is, how much hypoxic, and out of proportion the hypoxemia to the amount of lung involvement. I'll give this example that we see a lot. You have patients that will initially come with acute pneumonia. You got diffuse, ill-defined opacities bilaterally. Most of the time, it's more peripheral than central, but it can have different levels. This is more a severe case involving both sides of the lung. It's a little bit more on the right than on the left. And then it progresses in a few days, total ARDS. The lung is totally white out. This is severe alveolar damage. Patient's intubated. You can notice that the patient has an ECMO line because the patient was having severe hypoxemia. Unfortunately, this patient did not survive. So this is the worst presentation you can see. And this is probably dealt with mostly in the intensive care unit. In normal ARDS, before the time of the COVID, the way we understood ARDS happening, that there will be an infection, most of the time sepsis, pneumonia, occasionally ischemical from aspiration that will cause direct lung injury. There are certain comorbidities, the older the person, and certain comorbidities with them, pre-existing lung disease, there probably some genetic predisposition adds to it. And then on top of that, the mechanical ventilation mode, we know from the studies that's done in the last 20 years that lung protective strategies decrease the ventilator-associated damage. Before that, when people were using more than the physiologic volumes, there were more lung injury from it. Fluid balance had become very important, where you need to keep the patient euvolemic, especially after the initial stabilization of the patient. Is better than keeping them too wet. And all of these factors will cause some alteration in the alveolar capillary microenvironment. There will be edema, there will be inflammation, recruitment of multiple inflammatory substances. And you're gonna go in one of two directions. Either this inflammation will be reabsorbed, removed, and patient will recover, or is gonna progress into more fibrotic phase. So this is before the time of COVID. This is how we understood it. Now with the COVID, it's a little bit different because the SARS-CoV virus 2 is most of the time attaching directly to the ACE2 receptor, which is deep in the lung. And with that, it's triggering a lot of inflammatory responses that we are starting to scratch the surface of it. The angiotensin activation of that will affect the edema in the lung. The increase in the tissue growth factors will be affected. There will be a lot of edema with extra cellular matrix accumulation, and it will activate the myofibroblasts, and that can lead to lung fibrosis. What we've noticed early on in the COVID pandemic, a year ago around this time, when patients are surviving the acute phase, that they were going more in the fibroblast activation getting lung fibrosis. What we're seeing now with the second, or maybe it's the third wave since New Year, probably with the new variants, whether it is the B117 or the South African Brazilian, we're not getting as much fibrosis, as much as inflammation, leading to ground glass opacities that's prolonged even after the virus is cleared, that is lasting weeks and sometimes months. So I'll give you an example. A patient I've seen last year around April, 77, smoker. He came with atypical pneumonia, and he had ill-defined opacities bilaterally. He was tested positive for COVID. He was kept on high flow oxygen, treated with antiviral, treated with steroids. And it took him about 2 months in the hospital where we're able to wean down the oxygen to a level where he can go home with. And it took him about 6 months for total recovery. About a month after the initial attack, you can see where he's starting having more interstitial opacities bilaterally. When we've done a high resolution CT scan early on in the first 2 weeks, we are seeing this commonly, the pneumomediastinium, sometimes pneumothorax. You see the ground glass opacities and early signs of fibrosis. You start to seeing the bronchiectasis. 4 months down the road, most of the ground glass opacity have resolved. The patients start developing honeycombing. You got the increased interstitium. And then you see the bronchiectasis. Our radiologists read this as a typical UIP pattern, usual interstitial pneumonitis pattern, the pattern that you see usually in idiopathic pulmonary fibrosis. So at that time, the patient has been on steroids and slowly weaning it down to clinical improvement. We're very tempted at this point to start antifibrotics, but the patient clinically was improving. His oxygen requirement was coming down. Eventually, he was able to wean off oxygen, wean off steroids, starting going back to near normal activity. So this is one pattern that we're seeing. So I think this is more related to the initial variant that we have in the COVID virus. What we're seeing now with the second phase, more like this, patient variable age. This example, she was like 33, no pre-existing lung condition. She gets severe hypoxemia. She gets ground glass opacities bilaterally. Patients usually admitted, started on oxygen, antivirals, steroids. The lucky ones will improve in a week or two. They will be able to go home. Some of them will have this pattern for a month or two, and they seem to have less response to the steroids. Now, I had this patient was interesting. She had acute COVID, again, last year around March or April. She's young, in her 30s. She was hypoxic. And a month later, she was discharged, not using oxygen, but still having significant hypoxemia. She was still on steroids. The CT scan was not impressive. She had CT scan angiography when she was acutely ill, hypoxemic, D-dimer was high, developed hypotension. There was no PE at that time. They done an echocardiogram. There was no signs of right ventricular strain. A month later, the ground glass opacities were minimal, if any. We've done PFTs for her. All her volumes and spirometry were okay, but her DLCO was on the lower side, 61%. She was on steroids already and we tapered it off, but she still had symptoms 2 months later. We repeated her PFTs after her CT scan to detect her DLC was still low. So we've done a lung perfusion scan for her, and it showed there was a perfusion defect in the one of the segments in the right and another segment in the left, indicating that the patient probably had PE in her acute phase, and she's now more suffering of the chronic phase of it. So the dilemma was at this point, should we keep on anticoagulation or not? She's already 2 months past it. We checked her D-dimer back to normal. We checked all her coagulability workup, everything back to normal. Discussing with the patient, she herself has medical background, and we decided at this point, whatever happened. It's not progressive. The chance of recurrence is low in her, and we opted not to keep her anticoagulation. She started to be active, doing her own rehab, walking and exercising, and her function is very close back to normal. So we'll try to look on how common is pulmonary complication post-COVID infection. It's, as I said, a moving target. There's a lot of papers being published, but if you're gonna look in the past, so the previous COVID infections, whether it's the SARS or the MERS corona, when they've done studies on them, the SARS were, as you know, more in Hong Kong and in China, and they found there was some chronic changes in the patients. So some of them are persisting for a year. So these functional changes seems to be chronic. So we predict that they will have about the same percentage, maybe around 10%, maybe 20%, that patient will have some complications. And we're keeping an eye on it. I think depending on the variant, we're gonna see different patterns of complications. The risk factors for a patient to progress to lung fibrosis, advanced age, we find it very important. The older the patient, the more likely they have a severe illness acutely and post-acute phase. The more severe the initial pneumonia and the extent of lung involvement, chest X-ray, lab finding of lymphopenia, the leukocytosis, elevated LDH, ferritin, C-reactive protein, all of these factors, when there's severe inflammation, they are leading more to prolonged lung injury, whether it's an inflammation or fibrosis. Comorbidities, it's again a moving target. Being immunocompromised is debatable. There's a lot of studies showing patients who are already on immunosuppressants are less likely to develop fibrosis. They can get the COVID. And I had a patient who was on immunosuppression, developed COVID, and his lung function improved after COVID and was able to be off immunosuppression for almost 3-4 months. And later on, he had hypersensitivity pneumonitis. And after 3-4 months, he needed to be back on immunosuppression with Imuran and steroids because his symptoms have recurred. So being immunocompromised or on immunosuppressant, again, there's variable data about it. As expected, if they stayed in ICU for long, in the hospital for a long time, they had mechanical ventilation for a long time, they're more likely to have lung injury. Smokers, we've seen that pre-existing lung conditions, especially with long-time smokers, they're developing more symptoms, and it's taking longer to recover. Alcoholism, again, there's several reports indicating that they're suffering on the lung. In the Middle East, it's we don't see chronic alcoholism as much. So our experience is more coming from the Western countries where alcoholism is more prevalent. What do we expect when patients develop lung complications? They're either going to be staying the same, get better, or get worse. The course, we have some people get lung damage, stays the same, doesn't get better. What we are seeing right now, people are improving, the majority of them, some improving quickly in a week or two, some are taking 2 months or more to recover. What can we do for this pulmonary fibrosis? If you can prevent the infection, that would be great. Easier said than done, but now with the aggressive campaign for giving vaccines, we're starting to see a little bit decrease in the cases that we're getting. The oxygen therapy, which Dr. Ashraf will talk about it later on, we're thinking about the oxygen toxicity, that a lot of people are aggressive in treating patients, trying to keep their saturation at 100%. There is no direct data saying it's harmful, but we know from previous experience that there is oxidative injury. So we don't need to target 100%. Maybe keeping it around the 90% would be good. That's physiologic, patient can function, and you have the theoretical possibility of limiting that injury. Again, there's no specific study about that. If they need a ventilator, lung protective ventilation strategies, again, speculation. There's no randomized trials. It's probably going to be considered unethical to try to use large volumes. So everybody should be having lung protective ventilation strategy to limit the damage that comes from the ventilator. Prone positioning, it's being used more than ever. We're using even awake prone positioning for patient on oxygen without being on a ventilator. They changing position, staying prone for several hours, and we're seeing some improvement in their oxygenation with that. And as I said, it's becoming standard. Everybody gets anticoagulation for DVT and preventing PE. So this is the first step, trying to prevent these lung injuries. The other options that's being studied, we know steroids. There's the British study, probably one of the first that showed real improvement, decrease in mortality, decrease in morbidity that was meaningful clinically and was statistically significant. Among the patients, so they studied over 2,000 patients. They gave them a dose of dexamethasone with usual care or just usual care. And you find that among the dexamethasone, the mortality was 22%. Among the usual care, it was 25%. And that translated to a risk factor of death of about 83%. So that means there was about 18% improvement in mortality. And the risk for mechanical ventilation, again, was almost half for those who received dexamethasone. And for the patient requiring oxygen, went from 23% with dexamethasone, 26%, about almost 18% improvement for dexamethasone. But not for patients, those who did not require oxygen or ventilator support, there was no improvement from the steroid. So now it's becoming standard of care. You will see everybody that requires oxygen, has pneumonia of COVID, they're receiving steroids. The dose that was studied, dexamethasone 6 milligrams daily. You have other institutes that are using different forms. Methylprednisolone is probably the most common. Some are using higher doses without solid evidence, more like a clinical hunch. When the patient is very sick, we don't know if this is going to be good or harmful for the patient. But this was the design of the study when they compared the dexamethasone with the usual care, and they looked at those on ventilators. They had the best value was to prevent invasive mechanical ventilation. There was improvement in requiring oxygen, but if they did not require oxygen, there was no improvement by giving dexamethasone. So it has to be selective with it. In the other trial, the British trial, the recovery, they give dexamethasone 6 milligrams daily for 10 days. Now, this was done early on in the COVID pandemic when we did not have these variants that are more aggressive and lasting longer. So what you do after 10 days, if they're still hypoxemic, we don't have guidance from the clinical trials, so most people are going with their clinical hunch or previous experience. At this point, we're going to consider it as an organizing pneumonia, and they would require prolonged steroids. Most of us are opting to switch into something familiar with prednisolone, using about 0.5 milligram per kilogram. Most patients will be around 20 to 30 milligrams daily, and taper it slowly depending on the oxygen level. We find people who are recovering quicker, we taper them quicker. Those who are taking longer, requiring higher oxygen, we keep a little bit on a higher dose for a longer period of time. The problem keeping the steroids for long period of time or higher dose, we've noticed a lot of myopathy. They're getting very weak. Some of them are not able to stand up, and they're getting secondary infections. So it's a balance. So the data is for dexamethasone 6 milligrams daily 10 days. Anything beyond that is becoming more like a clinical experience. It will be nice to see that there are studies done about it. So the next thing that a lot of people think about, well, how about using antifibrotics, pirfenidone and nintedanib? And we've heard of colleagues in other countries where generic forms of antifibrotics are available and they're not expensive, that they already start using it. There is no specific data about it. We know from chronic idiopathic pulmonary fibrosis that the effect of antifibrotics was a small effect and was slow. So it takes time. Most of the studies showed that within 6 months to 1 year, it slowed the deterioration of lung function about 50%. So here, most people are improving already by the time you suspect you're going to have an effect in 2 to 3 months. So without a clinical trial, I'll be very hesitant to recommend that. Here in this country and most countries where there's only the brand name is available, you're talking about several thousands every month for a medication that has not been proven to work. So I would say it should not be the general practice here. Could it be done for those we've seen progressive fibrosis, not the granular opacity? So every month you're following them, they're still hypoxic and they're getting more and more fibrosis and patient getting worse, maybe. But as again, it shouldn't be general for everybody. With the oxygen therapy, I'm going to leave the details for Dr. Ashraf. Is going to have a full lecture about it. Pulmonary rehab, it's becoming more important the longer the person stays in the hospital, especially the elderly. We're finding a lot of them, the oxygen improved, but they're not able to function. They cannot stand up, they cannot walk just to the bathroom or the kitchen, and they're requiring rehab. We have people we had to keep in the hospital for weeks until they're safe using a walker, make sure there's enough help for them at home. We starting initiating inpatient rehab the minute we can start just having him sit up in bed or turn sides just to maintain as much muscle function. And it's a struggle. We have even people in their 30s and 40s developing severe myopathy, some of them neuropathy. So as early as possible, this should be taken care of. It's causing a lot of loss of function just because the patient is getting weaker and weaker. Now, you will see that beside the pulmonary problem, the muscles and so on, you're going to have people have depression, people with chronic fatigue syndrome. All of this need to be addressed. Vaccinations, again, encourage people to get their vaccine. We know the general recommendation about 3 months post-infection to get it. There's no harm for getting the vaccine before that, but since the vaccine amount is limited, so you give it to people more susceptible. Most people will have protective titers for at least 3 months. And You should be generous in recommending it to all your patients. The only contraindication of receiving vaccine is somebody received the first shot and they got allergic reaction as anaphylaxis. They shouldn't receive the second one. Everybody else should get the vaccine. And for those who have known severe allergies, then they should be monitored for 30 minutes afterward, but don't prevent your patient from getting it. How about other vaccines, pneumonia, influenza, and so on? It's probably as a general rule, but you probably need to space it away from the COVID vaccine. Lung transplantation, this is your last resort, very selected. I don't know anybody in this country has it done. It was reported in China where they done it for selected cases, but that's going to be for the very severe ones. Now, how about colchicine? We started seeing a lot of noise in the last couple months about colchicine. The studies that were published about colchicine were early on for non-hospitalized patients where it has some improvement outcome for them to require less oxygen, less mechanical ventilation. After they're sick in-house, we don't know. So you need to be careful about it, about the toxicity of it. I think I will stop here. And then if there's, once Dr. Ashraf finishes the further studies, then we will proceed with the further discussion.
Thank you very much, Dr. Youssef. Very interesting. I think we still need to have a lot of questions for the lecture because it's one of the hot topics. I would like to introduce Dr. Ashraf Al-Houfi. Actually, Dr. Ashraf is a graduate from Alexandria, Egypt, and then pursued his further studies, and he received his MRCP and FRCP in 2008, followed by where Dr. Ashraf had his diploma in intensive care in 2012, the European diploma, and currently Dr. Ashraf is currently the head of department and a consultant in Dubai Hospital. Without any delay, I would be pleased to keep Dr. Ashraf on board and allow him to start his presentation.
Thank you very much, Dr. Abdullah, for the introduction. And thank you for inviting us to be part of this scientific event. Bismillah ar-Rahman ar-Rahim. To start with, I'd like to thank Dr. Youssef. He reminded me with my old time when I was a pulmonologist, because you know I'm already a full-time dedicated intensivist for almost 30 years now. But for the 5 years before that, I was a pulmonologist. So thank you, Youssef. You remind me with my old days. I will share my screen with you, and hopefully that you will be all seeing it with me. Can you see my screen?
Not yet, Dr. Ashraf.
Okay. Just a minute.
Yes.
It's now okay?
Yeah, it's okay.
I'll just make it full screen. Is it okay now?
Yes, Dr. Ashraf.
Okay. Okay. Bismillah ar-Rahman ar-Rahim. A little bit different from what Dr. Youssef presented, since he was focusing mainly on COVID-19 pandemic. I will be more generic. More generic because oxygen therapy is really one of the very important interventions in medical practice in general. Yes, in the time of COVID-19, oxygen became one and probably the one and only, which is being used for everybody who's been admitted to the hospital and even later on. So we need to talk a little about that, and those are some of the learning objectives. One of the very important facts which we need to know about oxygen, that it's a life-saving drug. And like any drug, you need to write it as a prescription. You cannot, for example, tell a nurse, give an antibiotic. When you want to give a patient a piperacillin tazobactam, you have to give the prescription very clear. You have to tell her, give 4.5 grams IV as a bolus over 30 minutes, followed by 4.5 grams as an IV 6 hourly by infusion over 4 to 6 hours. This is a prescription. You cannot just give antibiotic. The same way we should deal with oxygen. Oxygen is a drug, it is life-saving, and should be prescribed. One important fact about oxygen, probably Dr. Yusuf alluded to, is you only need to give the oxygen as much as needed. There is no need to give excessive oxygen thinking that that is better for the patient, because your body cannot store that oxygen. Unfortunately, the majority of the healthcare workers dealing with our patients have little information about how to give oxygen. Now, giving oxygen without prescription is quite common. So in a British Thoracic Society survey, they found a large number of patients who are already on oxygen. You go through their files, there is nothing written about how to give that oxygen, what is the concentration, the way you give, the target you want to achieve. And even if you write it properly, you will find lots of people who are not receiving it properly. In addition to oxygen, we have to understand that oxygen is only one element of the resuscitation of a critically ill patients. Because, for example, if your airways are not patent, then the oxygen will not benefit you. Then giving oxygen to a patient without safeguarding the airways or without improving the oxygen delivery, because we know that oxygen comes from the lung to the blood, but it is carried by the blood through the cardiac output down to the tissue. So if you don't improve the oxygen delivery to the tissue, then your oxygen, which you are giving to the patient, is not of a great benefit. You can give how much oxygen you want, but if there is no enough hemoglobin to carry it, or if there is no adequate cardiac output to push it down to the tissue, then the tissues will not benefit because there is no proper oxygen delivery. Giving oxygen to a patient without, for example, taking care of the underlying etiology is of a great disturbance. Because if a patient is in morphine overdose, no matter how much oxygen you will give him, if he will not pay attention to the underlying problem, like a paralytic agent or a respiratory depressant, then your patient will not be improved. So despite oxygen administration is extremely important, despite oxygen administration is a life-saving one, but we should establish the reason of hypoxia. So giving oxygen to the patient is only the one step in order to prevent serious outcome. But you should look for the underlying cause, try to correct it, because if you don't deal with the underlying cause, then the oxygen administration will not be very beneficial. So it is now very apparent for us that if you want to give the patient oxygen, the patient who will benefit from it is the patient suffering from hypoxemia. All of us think that only hypoxemia happens because of pulmonary causes. Yeah, that's common. It's a common thing, that the respiratory system is the system responsible for the gas exchange. So respiratory failure will always be the cause of hypoxemia and requiring oxygen. But back to a little physiology, we have to understand that when we talk about oxygen, we have to differentiate between what we call the FiO2, which is the fractional concentration of oxygen in the inspired air, the FiO2. But if you talk about oxygen, which our body utilizes, we need to talk about the partial pressure of oxygen. And if you want to talk about the partial pressure, then the FiO2 need to be multiplied by the dry air barometric pressure. This means the barometric pressure minus the water vapor pressure. So despite the FiO2 at your nose is 21%, but the partial pressure of oxygen is around 149 millimeter mercury. And this is what we call the oxygen cascade. So if your oxygen is low, because low FiO2, low percentage of composition, like for example, if you are staying in a room where there is a fire, where oxygen is consumed and it is full of carbon dioxide and carbon monoxide, then you will become hypoxic, even before the fire or smoke will cause damage to your lung. Or if you go to the high altitude, where the pressure will go down, despite the percent composition is low, you will still develop hypoxemia. So those are two types of hypoxemia which will benefit from administration of oxygen, but none of them is due to respiratory failure. But because of pulmonary problem, like for example, hypoventilation, you will start to become hypoxic. We all know that ventilation is a process by means of which air enriched with oxygen is driven in and out of the respiratory passages. It's a mechanical process, yes, but it needs a very integrated central control, neuromuscular integrity, muscle power, and patency of the air passages. If any of those are impaired, and if you take a small look here, you will see that the impulses in order to drive the respiration is coming from the brainstem, and it is going down to the anterior horn cell of the spinal nerves, particularly the phrenic and the intercostal nerves, which will make a supply to the intercostal muscle and the diaphragm. And once this will move, it will lead to the process of ventilation. So you are expecting that if you have any problem at the brainstem or the spinal cord or the neuromuscular junction or the muscles itself or the airways, that you will suffer from a hypoventilation. And we know that hypoventilation will always be associated with a degree of hypoxemia and hypercapnia, which we call the type 2 respiratory failure. Probably the one which of our interest, particularly when we are talking about the COVID-19, is the hypoxemia resulting from the damage at the alveolo-capillary membrane. We probably know that this membrane, which constitute the alveolar wall and the interspecies space, as well as the capillary endothelial lining, we call it the alveolo-capillary membrane. This alveolo-capillary membrane is very thin and it's very big. And this is to our advantage because it allows oxygen to diffuse freely from inside the alveoli to the bloodstream, which will later be taken up by the capillary blood. But diseases which result in destruction in the alveolo-capillary membrane, either by inflammation like alveolitis or fibrosis like this, or destruction even by emphysema, will result in a diffusion defect. And the diffusion defect will result in hypoxemia. And the time and concentration of oxygen at the alveolar level needed in order to improve the oxygen in the blood will become much higher. Probably the mechanism which is puzzling us all is the VQ matching. In the perfect world and perfect lung, all ventilated alveoli must be perfused, and all perfused capillary must be ventilated. So every oxygen coming to the alveoli must need a blood coming in the capillary. But unfortunately, sometimes some ventilated alveoli are not perfused. So they behave like a dead space. Or some perfused capillaries are not ventilated. So they behave like a shunt. And if part of the lung become dead space or become like a shunt, then you develop by default hypoxemia. And that's very important cause of hypoxemia, which require oxygen therapy. The last one which we need to mention is the shunt. Now, if the alveoli are not properly functioning, then probably the blood coming from the pulmonary arterial side to the pulmonary venous side is shunted. And no matter how much oxygen you give to the patient, probably he will not improve. I want to remind you with those shunt curves, which we used to tell to our students before, that the higher the shunt fraction, the more difficult it will be to correct the hypoxemia. And if you go to the lower shunt fractions, like 50%, no matter how high the oxygen you will give, the patient will continue to be hypoxic. And the example for that is the anatomical shunt. If a patient is having anatomical shunt, like for example, a Fallots tetralogy, the patient will always be cyanosed no matter how much oxygen you give, because a large portion of the blood is shunted from the right side to the left side without being oxygenated. Talking about that, then it's very important to know that with this background physiology, giving oxygen to the patient will probably be your first step. But those first steps should be followed by several steps to know what is the triggering factor and what is the underlying illness. Otherwise, giving oxygen alone to the patient will not be enough. When we talk about oxygen therapy, we have to understand there is too many modes and varieties. And today I will talk about few of them. Of course, I cannot talk about all of them in details because each one of them, like for example, the invasive or the high flow nasal or the ECMO, will need a presentation by its own, but I'll just give an overview of it. So we may have either a low flow or a high flow oxygen. We may have an uncontrolled or a fully controlled oxygen therapy. We may have this low or high flow at either normal or high pressure. We may use this oxygen delivery either non-invasively without putting endotracheal tube or invasively by using the mechanical ventilation. But in both circumstances, you are using the pulmonary, both the pulmonary parenchyma and the pulmonary capillaries in order to oxygenate. Or you can go outside the system and give an extracorporeal oxygenation to the body. And we have to remember that later on, some of you patients will require to have this oxygen at home. Probably the most convenient way of giving oxygen to your patient, particularly if they are not suffering from severe hypoxemia, is the nasal cannula. The advantage of the nasal cannula, which we consider as a low flow, but it is uncontrolled oxygen, so you cannot really precisely know how much oxygen the patient is taking. But by default, we are trying to give 1 to 2 liters, which is increasing around 4% every time you increase. What is nice about the nasal cannula is it is very convenient. The patient can eat, can drink, can talk, can speak, can do respiratory exercise, can cough, can produce the phlegm outside, can do all the incentive work in order to do that. And what is more advantageous of it, that it is also can be given, if it is at low flow, for a long time with a very little toxic effect of the lung, and it is one of the most commonly used oxygen therapies at home. But apparently, it will only need someone with mild hypoxemia in order to be effective. If that patient is becoming more hypoxic, then you probably need to use the simple face mask. We call it the Venti, not the Venturi. This is something else. The Venti mask is a little still low flow, but you can use a higher flow than the nasal cannula, and it gives you a better oxygen concentration up to 60%. You don't have to use any lower flow than 5, otherwise you will not be able to give the patient even at 40%. Apparently, it is better oxygenated than the nasal cannula, but you have to remove the mask every time the patient needs to eat or need to do respiratory exercise or inventive spirometry or to bring his phlegm out. A higher oxygen sometimes is needed, and this is what we talk about in the non-rebreathing. The non-rebreathing face mask is usually having a reservoir bag. This reservoir bag should be full at all times, because keeping a higher concentration at all times near the respiratory system will increase the concentration. So by using 8 to 15 liters in a non-rebreathing reservoir bag mask, it will result in a good oxygen supply of almost 75 to 80%. Some people are thinking that if you go to 15 liters, you can reach 100%. We've tried this before by an external oxygen sensor. It never reaches 100%. So you can maximally reach to 80%, even if you are 15 liters. But 80% is a good oxygen concentration, which can give the patient an adequate amount, particularly if they have a moderate severity of hypoxemia. What is also important is that the reservoir bag must be full all the time. So sometimes we hear the term non-rebreathing. If you want to talk about a fully non-rebreather oxygen mask, this means that there is a little valve which is between the reservoir bag and the mask, which you open during expiration and close during inhalation. The important is to give the patient the chance to have the highest possible concentration of oxygen at the highest flow at all times. This is why we call it a non-rebreathing. Remember that all of those oxygen are still under pressure, because I will be talking later about under a higher pressure. All of those methods of oxygen administration are usually uncontrolled. You remember that I'm telling to you, it may give you 24 to 40, 40 to 60, 60 to 80. So it is all average. The only way of oxygen administration by a mask which is controlled, we call it the Venturi mask. The Venturi mask, as you can see, it has separate pieces, and those pieces have a special structure which works through something called a Bernoulli phenomenon. Bernoulli phenomenon means if you give a high flow through a small hole, this will make an entrapment of the air from outside to inside. So the flow will go inside with 21 oxygen, but it entrapped from outside more oxygen. And by the size of the hole and the flow of oxygen, I can precisely control how much oxygen I'm giving to the patient. So I can give the patient 24 or 28% or 31%, 40% or 50%. In order to make it easy for everyone, it usually has a color code. So you don't have to know which one is the yellow, which one is the blue, which one is the green, which one is the white, because it is written on each piece. What is the concentration of oxygen it will deliver and how many liters you need to give in order to achieve this. Why do we need to have a controlled oxygen? Sometimes some patients who are chronic hypercapnic respiratory failure, like COPD patient, it's very important for them to avoid uncontrolled oxygen administration. Because after a long time of being hypercapnic, the respiratory center loses its sensitivity to the hypercapnia as a stimulant to the respiratory center. So if you eliminate this hypoxemia, which is stimulating the respiratory center, then the respiratory center will become further suppressed. So a COPD patient with chronic respiratory failure, chronic type 2 respiratory failure, with a CO2 retention, if you give them a high concentration of oxygen uncontrolled, you may eliminate the hypoxic drive and the patient become more hypercapnic and go into a hypercapnia or a CO2 narcosis, which is something not good. The patient can be with controlled oxygen saved from being intubated. By using uncontrolled high concentration oxygen, they may go into CO2 narcosis and then you have to intubate them unnecessarily. That is why the Venturi is one of the very common and very well used method of oxygen administration, which is called controlled oxygen therapy to chronic type 2 respiratory failure. All the previous oxygen therapy methods which I mentioned are different flow, but all at the same pressure. Now we have a different way of giving the oxygen. I told you that the oxygen concentration at the alveoli determines how much of this oxygen will diffuse through the alveolo-capillary membrane. So you can imagine if you increase the oxygen concentration and if you increase the flow by means of which you give that oxygen to the alveoli, as well as increasing the pressure by means of which the oxygen is applied down to the alveoli. This means it will further improve the ability of the oxygen to diffuse through the diseased alveolo-capillary membrane. One of the major problems we face in parenchymal lung disease, COVID-19, is on the top of them, particularly if it is our major problem. Now, high flow nasal oxygen supply became one of the most commonly used methods of oxygen administration during the COVID crisis. You can see a lot of people have been saved from being intubated because of this high flow nasal. What is important about the high flow nasal that it is leaving the patient's mouth and face still exposed. This means they still can talk, they still can cough and bring the sputum, they can still eat and drink, they can still do the respiratory therapy and breathing exercise. It can be used through a special device and sometimes through the ventilators, which can do that. The only problem with the high flow nasal that it really consumes a lot of oxygen. Unlike even the ventilator, as you all know, has two ports, one of them mid-air or sometimes compressor, which run the pressure, but then you supply the oxygen for oxygen supply only. The problem with high flow nasal that it uses the oxygen to operate the system. So it consumes a lot of oxygen, but we know it is very beneficial. It has a small CPAP effect. So the higher the flow, you will find that the CPAP effect is always better. Take a close look at the two curves. You will find that there is a higher curve and a lower curve. The reason for that is if the patient keeps his mouth open all the time, you can lose that CPAP effect. But generally speaking, if you increase the flow of the high flow nasal, there is a little CPAP effect, which is always beneficial. This means the pressure of oxygen at the alveoli is always at a higher level, which allows the oxygen to diffuse better through the diseased alveolo-capillary membrane. The second important point that the high flow of the high flow nasal flush the carbon dioxide out. So generally speaking, if you increase the flow of the high flow nasal, you will probably increase the carbon dioxide wash out. Of course, that doesn't mean that we use the high flow nasal to treat hypercapnic respiratory failure, because in the insert leaflet of the original studies of the high flow oxygen therapy, you should not use it for hypercapnic respiratory failure. Because if you give the patient too much oxygen, it is not documented that you will be able to remove the carbon dioxide. But the trials which is being conducted have shown that at a higher flow, this means 30 liters per minute, 60 liters per minute, more carbon dioxide will be removed from the upper airways, which is beneficial. Not to mention that the high flow nasal decreased the work of breathing. Look at this, you will find that the work of breathing is minimum when you are using the high flow nasal or the non-invasive compared with the non-rebreather or the regular oxygen therapy. We know from the trials which is being conducted on the high flow nasal that it is beneficial in preventing intubation and re-intubation after extubation. So in this study, as you can see, a large number of patients have been tried, but the high flow nasal cannula reduced the need for intubation when it is compared with oxygen conventional therapy only, but it was equivocal when it comes to non-invasive. The same study have told us that after extubating the patient, if you put him on high flow nasal, you decrease the possibility that this patient will become re-intubated. So comparing the conventional oxygen therapy, whether it is low flow, whether it is high flow, non-rebreathing, venti, venturi, compared with the high flow nasal prevent intubation better than the regular oxygen therapy and prevent re-intubation after extubation in all patients with acute respiratory failure. As long as we mention the high flow nasal, we have then to go to the non-invasive ventilation. Non-invasive ventilation, this means you will not only use oxygen, you will not only use flow, but you will also use a controlled pressure delivery system. This means you will use a ventilator in order to intermittently or continuously inflate the lung with a pressure and the air enriched with oxygen. This means you need to have an airtight, sealed mask. So there's a lots of masks, which is either the nasooral or the total face mask, or recently from the Italian group, we have the helmet. And the helmet was actually very convenient. We tried it several times in the current situation, and it was very good. Now, this helmet is not optimum one. The helmet which we tried on our patient has some opening here where you can give the patient some straw to drink. And there is a big opening here where you can even open it and give the patient something to eat. And it proved to be very beneficial. According to the British Thoracic Society guideline, the non-invasive ventilation was originally indicated for the people with COPD, with acute exacerbation and chronic type 2 respiratory failure, with acute on top of chronic. And you can see it was a 1A recommendation. The indication was very good for a COPD with acute exacerbation or for any kind of hypercapnic respiratory failure. But they later on realized that it is very beneficial to all patients suffering from acute respiratory failure, including cardiogenic pulmonary edema, and immediately to help the patient early weaning, early extubation, and prevent the re-intubation. And we can see that because it depends on a patient who is having an intact upper airway structure to prevent the vomiting and aspiration, impaired consciousness or an unconscious patient or severe form of hypoxemia and hypercapnia, or the presence of copious secretion can be considered as contraindication to this. Non-invasive ventilation is very beneficial because it really decreases the incidence of intubation. It prevents the people from being re-intubated after being extubated, so it has a beneficial effect. And this is already documented in the British guidelines. Some studies have tried to compare between the high flow nasal and the non-invasive ventilation to see which one is better. And of course, this trial in particular have shown that despite the high flow nasal was better than the conventional oxygen, it was not very much superior to the non-invasive ventilation on the long term when it comes to the rate of intubation and the rate of re-intubation. You can see that the curves here are almost coming together when you compare between the high flow nasal and the non-invasive ventilation in preventing re-intubation after extubation in cardiac surgery patients. Of course, this is not a method of oxygen administration. This is a method of maintaining a level of oxygenation when all of the above failed, and you have to go to a different level of oxygen supply to the patient. So ambo bagging is not a method of oxygen administration. It's a rescue method to maintain oxygenation till the next step, which is using the invasive mechanical ventilation. Because if you don't do this properly, then probably it might hurt the patient. Using the mechanical ventilation to supply the patient with proper oxygenation is a difficult task. There is hundreds and varieties of ventilators. There's hundreds and varieties of ventilator modes, and you have to be expert in using those ventilators in order to benefit your patient with the oxygenation. And of course, each disease, whether it is obstructive or restrictive, has a different method and a different move. And I can say that it should be a personalized experience with each patient. You cannot use a dogmatic ventilator setting in order to improve oxygenation for the patient. Some people need a higher peak, some people need a lower peak. Ventilator strategy should be tailored for each patient according to the disease condition and according to their response to the treatment. I cannot talk more about that because talking about mechanical ventilation might be a different lecture. Of course, all of the previous system, we were talking about using the lung to oxygenate the blood, whether by administering the oxygen at low flow or high flow, at low pressure, at high pressure, invasive or non-invasive, you are still using the lung. When the lung cannot provide your body with the oxygen, then this is the time we go to the extracorporeal system. Extracorporeal membrane oxygenation means I don't depend on the lung at all to oxygenate the blood in order to deliver oxygen to the tissue. I take the blood from one vein, I pass it through a pump outside an oxygenator, then I give it back from another vein. Then I don't need to depend on the lung to oxygenate the blood. Now, the extracorporeal membrane oxygenation, or the ECMO, is a big topic which need to be said on its own, because there is a lots of limitations, lots of indications, lots of restrictions, and lots of technical issues which we need to talk about it, of course, which is beyond this presentation. Now, some of the patients who require oxygen in the hospital will probably need that oxygen later on at home. What is very important is that there is a big variety of oxygen to be delivered at home. You can use the oxygen concentrators or the cylinders or the liquid oxygen or compressed oxygen. What is very important for you when you are prescribing oxygen at home level, that you should know the level of activity of the patient, how dependent the patient is on oxygen, what kind of lifestyle they have. Are they ambulant and moving and cooperative? Because you don't have to be a bed-bound or bed-restricted activity, because some of them can be oxygen, some can be with an assisted device, and those devices can be very quite useful, particularly for patients with tracheostomy or for patients who's having certain obstructive or sleep-related illnesses like the nasal CPAP and BiPAP at home. And it is very important to know that the home oxygen therapy can set the patient free. You don't have to be restricted anymore, because there is too much and too many varieties which can help the patient to use the oxygen and live his real life and enjoy his life as a normal human being. With that, I thank you very much for listening to me and enjoy the view. Hopefully all of you are having an oxygen concentration which is rising to the end. So I leave you at 99%. And thank you very much for listening.
Thank you very much, Dr. Ashraf. Interesting lecture. Actually, before we go for the discussion, I would like to announce the third event that the Emirates Society of Internal Medicine will be launching on 24th of March. And that will discuss on the emerging COVID-19 medications with Dr. Jihad. I have a few questions to run through the discussion. Dr. Youssef, what do you think about the use of antibiotics in COVID-19 infection? We've seen some patients, some practice to start antibiotics from the beginning for any patient who's COVID, but to cover any superimposed bacterial infection. But some people will say, oh, it's all related to COVID. So what do you think about it?
I think it should be case by case, should not be routine. Everybody gets antibiotic. That will be an overuse. You're going to have some pressure selective. So if there is a bacterial infection, you're selecting resistant bacteria. So I would say if you have evidence, you have neutrophilic leukocytosis, you have lobar pneumonia, picture on the chest x-ray, your procalcitonin is high, something to indicate you have purulent sputum, then yeah, you say there's an infection, I need to treat it. Now, occasionally patients who are very sick and end up on a ventilator, a lot of them will get antibiotics just because by the time they reach the ventilator, they've been sick for a week or two. And the chances of second infection is higher. So at this level, people are erring on the side of that individual person and giving antibiotics. But I say if you are using your judgment, don't use it indiscriminately. You have to determine that, yes, there's high risk for bacterial infection, then I should use it, but not for everybody.
Well, thank you. Dr. Ashraf, we've been in the clinical practice, but I'm asking in the ICU, have you found any difference between the non-invasive ventilator and the high flow nasal? Though some people are with, like, let's give a few hours of non-invasive and then give a few hours of high flow. But our RT, because of the increased demand, saying, oh, we can either provide this or that. Or shall we choose it in people who are more of a retainer, CO2 retainer? So what is your evidence that you had in practice?
Okay. Now, the high flow nasal is excellent in providing oxygenation. And if the patient can keep their mouth closed, even their oxygenation will become even much better. Our only problem, if the patient is hypercapnic, you will not be sure that the high flow nasal will clear that carbon dioxide. So we have tendency to categorize our patients. If they are still not hypercapnic or about to be exhausted, where ventilation is failing down because of muscle weakness, high flow nasal will be the preferred mode of oxygenating them. Particularly, the patient can still talk and eat and do incentive spirometry and chest physiotherapy, which is actually in itself is beneficial. On the other hand, the non-invasive, if you properly seal the mask and if you properly set the ventilator to synchronize with the patient effort, it will improve the ventilation. And we know for sure that if the ventilation is improved, both oxygenation will improve and elimination of carbon dioxide will happen. The only problem is when the time on non-invasive ventilation becomes prolonged, then the patient cannot remove the mask to eat, cannot remove the mask to drink, cannot remove the mask to do incentive spirometry and breathing exercises. It can even increase the stickiness of the secretion. And as long as you don't do chest physiotherapy, you will even further deteriorate the condition. So it's a bit balanced between them, but usually the high flow nasal improve the oxygenation, the NIV improve the ventilation with improving both oxygenation and removing the carbon dioxide, with the downside of not being able to do chest physiotherapy and respiratory therapy.
Thank you, Dr. Ashraf. Dr. Yusuf, in clinical practice, patient with underlying lung disease, either obstructive or restrictive lung disease, like the asthmatic patient, the COPD patients, do they behave worse? So do they have a standing bad prognosis from the beginning?
I'm sorry, I missed the first part of the question about which patient have more worse.
In patients with underlying lung disease, like obstructive lung disease or restrictive lung disease, have you evidenced any worse prognosis in these patients, like in asthmatic and COPDers, in obesity hypoventilation syndrome and cystic fibrosis? So what have you recognized in practice?
So it depends on the disease. Cystic fibrosis patients, usually they fared well just because they're younger. And usually all the reported cases, cystic fibrosis, usually they do better than the average person. Asthmatics, in general, they're faring very well. They're not more likely to get the infection. And there's some report indicating that the eosinophils are protecting them from the neutrophilic inflammation. So they might be protected. But patients who have COPD, interstitial lung disease, obesity, hypoventilation, they tend to do worse. So depending on the disease.
Dr. Ashraf, in looking at the patients with pulmonary rehabilitation, do you think incentive spirometer does more damage or does it help more?
No, the incentive spirometry and the breathing exercise are extremely important. One of the issues which the people are afraid of, that they think that because the lung is becoming fibrocystic or more fibrotic, or it has some bully or cavitary lesion, if they do incentive spirometry, it might result in some barotrauma. I'm telling you that that's not true. Doing the incentive spirometry is extremely important. Breathing exercises are extremely important. And if you don't do it, you probably will lose a big part of your lung. We, as Dr. Yusuf explained in his presentation, have no treatment. There is no good treatment for the lung fibrosis. Our only chance is try to prevent its progression. All the treatment which is being given is trying to slow down and reverse some of the fibroblastic activity. So you have to be very aggressive in the chest physiotherapy, in the breathing exercises, in the incentive spirometry, and we've seen real results. People who have been prevented from being re-intubated, being prevented from going to a long-term tracheostomy and home ventilation, being weaned off and decannulated from tracheostomy based on the rehabilitation and breathing exercises and the incentive spirometry. It has to be very much followed by the patient, and the respiratory therapist has to put his feet down strongly, because if they do that, they have a much better outcome than any treatment we know for the severe lung injuries happening to those diseases.
Thank you very much. Dr. Yusuf, a question with regards to the images you have showed. Some people were asking, what can cause the mediastinum or subcutaneous emphysema in COVID? So what has led to such an aggressiveness in this illness?
I think Dr. Ashraf probably have seen it more in the ICU. What we're seeing, that patients who have extensive disease, some of them are developing true lung damage. And you can see on their CT scan that they have like a pneumocele, they have destruction of the lung, becomes very stiff, and some we never see anything, we don't know. But it's usually indicative of a more severe course. The pneumomediastinum by itself usually is not treated unless it started to extend to pneumothorax and starting compromising the breathing. But it's very common for it to resolve spontaneously.
One extra point I'd like to add on this, that during this particular second wave, it was very evident spontaneous barotrauma, and the patient on even non-invasive and high flow nasal are developing subcutaneous emphysema, mediastinal emphysema, pneumopericardium, and spontaneous pneumothorax. Apparently, this disease, particularly the new wave, is more necrotizing. It's more acute, it's more aggressive. So in the second wave, which is in the last month and 1.5 months, more cases of barotrauma we have seen. I can tell you that my colleagues from the thoracic surgery working in Rashid Hospital, they have set a new record of how many intercostal tubes they inserted in Rashid Hospital during the last 2 months. It is exceeding the number of intercostal tubes inserted over the last 2 years. It is something which was very strange, but this new variant of the COVID infection, particularly in the last 2 months, is really more aggressive, causing more barotrauma, even at a spontaneous level and more at a non-invasive level, not to mention for those people on the ventilator. I have a patient now currently in my ICU on ventilator and on ECMO, and he has 3 intercostal tubes, 1 on the left and 2 on the right.
Dr. Ashraf, I would like to ask you, in the ICU, as we have recognized a lot of critical illness neuropathy, where patients, due to intubation, lose their muscle mass. And that would add an effect on patient being difficult to be weaned off from ventilation. Do you think anything can be done to that, like intensive physiotherapy? While is that any of help in your practice?
Yeah, to tell you the truth, Abdullah, the recommendations by the international guidelines was the reason why more people are developing critical care neuropathy. When you put patients deeply sedated and paralyzed on a very uncomfortable ventilator setting where the patient cannot tolerate to be awake and spontaneously breathe, then you have to deeply sedate, because every time the patient will fight the machine, you have to put them down to sleep. And if you fail with deep sedation, you even paralyze. So those kinds of ventilator setting and kinds of uncontrolled sedation and muscle relaxation for a longer time resulted in severe weakness. Nobody is paying attention to the importance of nutrition. Now, people staying on the ventilator for 2 to 3 weeks, and nobody is paying attention to the protein content of their nutrition, they lose significantly their muscle mass. Nobody is doing any passive exercise to patients on the ventilator, particularly too many people are afraid because the patients are COVID positive and they are afraid to stay with the patient for a longer time to do physiotherapy. Nobody is even using the more passive ways like the cycling, which can be attached to the patient in order to preserve some of the muscle mass. People are thinking that the cycle should be active. Actually, the cycling can be passive. You can put the legs of the patient on the cycle and the cycle can go, and it do improve the muscle mass of those patients. We do have a problem with the patient after being weaned off the ventilator. They are easily, because ICU doctor will always be more interested in getting the patient out of the ICU. Do a tracheostomy, put him on a portable ventilator, send him somewhere else. We see that patient after a couple of months, he is skin on bone. He's lost all his muscle mass because nobody is neither paying a good attention to his nutrition nor to the physiotherapy. Post-acute care rehabilitation is extremely important. And it starts from the first day you put the patient on sedation or muscle relaxation on the ventilator. You cannot neglect the patient for 3-4 weeks and they say, I will do it later on to catch up. What is being lost is very difficult to be built again. So absolutely, I do agree. Nutrition, physiotherapy, decreasing the level of sedation, avoiding the heavy sedation and muscle relaxation is the only way out in order to keep the integrity of the muscle mass, in order not to have a long-term disability and the long-term dependency on the ventilator.
Thank you, Dr. Ashraf. Dr. Youssef, a question with regards to the anticoagulation use, that we know that post-COVID pulmonary complications can have both, either the fibrotic or the thrombotic. So we have PEs that can, what is your recommendation with regards to the anticoagulation use? Some people use it for 10 days after the infection. Some people will depend on the dimer level, but what would you recommend?
There's no good study at this point for long term. We know everybody, minimum, they need a prophylactic dose. So for most people, going to be 40 milligram daily. Now, common practice, we're looking at the D-dimer. So you see patients, their D-dimer getting to, depending on your hospital numbers, for us, anything above 1 is considered moderately high, above 3 is considered severely high. So you see most people in the moderate range, they're using 40 milligrams twice daily, and above 3, they're giving full therapeutic dose. There's no data about it. Now, as long as they're in the hospital, the limited mobility, they need to be anticoagulation. Once they leave, the common practice, we don't send them with anticoagulation. I've seen some go with anticoagulation, but I would say if they're mobile, there's no evidence of thrombosis, they're okay. Especially if you repeated the D-dimer before they left and it's back to normal. The chances of them developing DVT-MP has not been reported. And we haven't seen it. Patients leaving the hospital, coming back with DVT-MP. We've seen it inpatient. This is happening where the anticoagulation has been neglected, it dropped over the weekend or something like this. So I would say not routinely, everybody should go home with anticoagulation without evidence of DVT-OP.
Dr. Yusuf, see, sometimes we don't do the imaging because kidney function, especially initially, you will be having acute kidney injury. Patient will be dehydrated, not drinking well. You will not do it initially, and then you will depend on the dimer level. But is there any tendency, if we have performed CT angios for patients with persistence of their dimer level that is a bit high, between 1 to 3 or above 3, for the duration of anticoagulation, like we will put them on a 6 month after the evidence, when is the role of repeating CT pulmonary angio to diagnose pulmonary embolism?
So the idea of anticoagulation, you're not treating the PE that happened, you're preventing the next one. So if the patient already cleared the virus, the inflammation is gone, they're back to normal, there should be no reason for them to develop a new PE. So if you have no evidence of DVT or PE, and the patient hypoxemia was proportional to the lung involvement. So somebody, more than half of his lung is involved, they're requiring 5 to 10 liters of oxygen. Say, yeah, this is appropriate. Somebody has only 1/4 of his lung involved and he's requiring 15, 20 liters, and say, well, this is out of proportion, have high D-dimer, but kidney functions are good, I cannot do. So you have to do some clinical judgment, but we tend not to give extended courses of anticoagulation without evidence, and especially if you're in doubt, you can follow the D-dimer. Once the D-dimer goes low, you're safe. There should be no reason for ongoing hypercoagulability once the infection is gone. As said, if you're doubt, like this lady we had, DLCA was low, and we've done the perfusion scan. So although her CTA was negative, the perfusion scan showed perfusion defects. So she had small PEs where the CT scan missed, but that's 2 months post. D-dimer is normal. We've done hypercoagulability workup, just make sure she's not ongoing risk. There wasn't any ongoing risk. So what's the point of anticoagulation? You're trying to prevent the next one. She's not high risk for the next one. What happened, happened. So I think you need to be a little bit careful, not overdo. So first, no harm. If you don't have an evidence or a good reason to do something, don't do it.
Well, I think that's interesting. Thank you very much. Dr. Ashraf, I think we still have a few questions to finish, but one of the questions that we see I'm having here, is there any specific settings in the ventilation that can lead to a VQ mismatch? And that can affect.
Yeah, okay, that's a difficult one a little, because I have to go to the physiology of the ventilation. But let me explain something. When you are using a positive pressure ventilation, you are using something which is not physiologic. Normally, ventilation is negative. You create negative pressure, air comes in. In mechanical ventilation, you make the reverse. You push the air under pressure, so you are reversing the physiology. Normally, when you are breathing spontaneously, your ventilation will reach certain oxygen to certain alveoli, which usually are perfused. So normal respiration do a better VQ matching than positive pressure ventilation, because positive pressure ventilation is pushing the air under pressure and reach it with oxygen, which might open alveoli or reach certain alveoli, which is less perfused or more perfused. So probably the ventilator might result in some sort of a more VQ mismatch. What is the damage usually happen with the ventilator? When you are using a high volume, a high pressure, which is either volume traumatic to the lung or pressure traumatic to the lung, or you are using a very high driving pressure, this means it will become atelectotrauma to the lung. Those are the issues which we are usually trying to avoid when we put the patient on any ventilator setting. But every patient should have a setting which is suitable to them. You should use the volume and monitor the pressure. You should use the PEEP and monitor the compliance. There is nothing called the all patient needs a high PEEP. There's nothing called all patient needs a low PEEP. A high PEEP might result in overstretching of certain alveoli and increase the VQ mismatch and make the patient more hypoxic And we've seen this a lots of times. So ventilator setting is a patient specific. There is no two patients, even in the severe ARDS, who are the same. Patients who are non-recruitable might be even harmed when you put them on a high peak. So it's very important to know the characteristics, mechanics, and dynamics of your patient while you are using the ventilator. There is no single ventilator strategy which suits them all. We put some patient on APRV and they improve. We put other on APRV and we reach a CO2 of 150 with a dangerous life-threatening acidosis. You put patient on high P and some of them do get recruited and they improve. And some people get overstretched and they develop a lot of barotrauma. So there is no single ventilator setting which is set to improve the VQ or decrease the VQ. Every patient is one patient on their own. You have to tailor the ventilator setting according to the patient response to the ventilator trials which you are doing.
Thank you very much, Dr. Ashraf. I will take the last question with Dr. Youssef. Dr. Youssef, we know that NOACs has been introduced for the treatment of pulmonary embolism. Is there a practice to start it for prophylaxis instead of injections while the patient is, like, depending on the dimer level, we do adjust the NOAC doses? Any role of that NOAC instead of Clexane or low molecular weight heparin during hospitalization?
In theory, it should work the same, but there's no studies, nobody published large studies to tell us it's as good. Since we're all familiar with the Clexane, with the heparin, low molecular weight heparin, so we're more comfortable with it. We know how to check it. We know if there's bleeding, how to recover it. With the NOACs, sometimes it's hard to detect how much the patient is responding, to check for activity, reversing it. So that's why we're avoiding it. I say just stick with the old guns, what you're comfortable with, and don't try reinvent the wheel. There's a lot of things we don't know about the disease. We don't need to add things that can cause more harm than benefit.
Well, thank you very much, Dr. Youssef. I think we came to an end. It is already 9:30. I know we have a lot of other questions that has been posted. I'm sorry we are not able to answer those questions. Thank you very much, everyone, for attending this session. I hope you all enjoyed the nice discussion that we had. And thank you very much, Dr. Youssef. Thank you very much, Dr. Ashraf. And I would like to thank ICOM also for their participation in holding and arranging this event. Thank you very much, everyone.
Thank you.
Thank you very much.
Enjoyed it.
Have a good night. Thank you.